Okay, I think it's close to 12, so it's a pleasure to introduce Norma Coe. She has a PhD in economics from MIT. She spent time at Boston College and University of Washington before she joined the Medical Ethics and Health Policy Department at the Perelman School of Medicine last fall. She's already talked to my class, so she's reaching out to our students and
Sorry
faculty.
for those of you who have to hear me twice.
Her research focuses on the effects of policies that directly or indirectly impact human behavior, healthcare, and utilization. She's done quite a bit of work on long-term care insurance, and its effects on healthcare utilization. Her research has been published in leading economic journals and health policy journals. And her ongoing research, which is funded by NIA, focuses on the costs of Alzheimer's disease related dementia. So we're some of the first to hear about your new findings, right?
Yes,
so
yes,
welcome.
this is
I'm
new
glad
stuff.
you could join us.
Yeah, thanks so much for having me. And this is new. At least some of it is really new, and some of it's under review. Some of it is yet to be seen. So would love any and all comments along the way. Feel free to interrupt. Really couldn't do this work without Lindsay and Anirban, so we need to acknowledge them up front. Like Irma said, we also need to acknowledge the NIA, and of course, everything is my own and nothing that I say represents the NIH. So the motivation is pretty simple. So we have 5.5 million Americans with Alzheimer's disease and related dementias now, currently in the US. So that's 1 in 10 elderly Americans over the age of 65, and 32% of those ages over 85 have Alzheimer's or related dementia. And it's currently the 3rd to the 6th, depending on how you rank things and how you code causes of death, 3rd to 6th leading cause of death in the US. And just to give you a little bit of picture about people who have Alzheimer's and related dementias, all of our estimates are going to be people age 65 and older, which is still only 4% of the population that has Alzheimer's disease. It's really concentrated among the older, so 75 and above represent most of the people who have Alzheimer's disease. And despite the fact that there's recent evidence from Ken Lenga and others that the incidence is actually decreasing, right? Prevalence is going to increase because we're simply getting older, and so it's expected to over triple to 16 million people in the United States to have Alzheimer's disease by 2050, which is unprecedented for a chronic condition. So that's the motivation, is this simply that this affects a lot of people. We need to know what to expect in terms of forecasting the cost for care so that we know how much it's going to cost, as well as things like how can we intervene to lower the cost of care for people with Alzheimer's and related dementias. So the overall goal of this entire funded project is to build forecasting models to predict the cost of care. So we have to take into account things like what type of insurance do they have? Do they have Medicare? Do they have Medicare Advantage? Estimate the healthcare costs for each different type. Figuring out what's driving these healthcare costs so that we might know some places to intervene. And importantly, there's also the welfare cost to caregivers. Most people who have Alzheimer's have someone helping to take care of them. It's not just the cost to the healthcare system. And so we have other work that's going on that's estimating the welfare cost to the actual caregivers. Today I'm going to focus simply on one of those bullet points, and even half of those bullet points. And so it's estimate the incremental healthcare cost of dementia within the traditional Medicare system only. So think about it as the fee-for-service Medicare program. And I want to try to answer 3 questions today. So why do the existing estimates range from $2,000 to $130,000? You'd think we should be able to shoot in a slightly smaller barrel. And I'll hopefully, as I go along, talk about some of the differences. We actually wind up on the lower end of the distribution. Want to look at then what's driving these healthcare costs. Alzheimer's and dementias is not something you can cure, so why are we spending so much money? Is it something that we should be thinking about in terms of waste or things we might be able to cut? And then finally, what can we do about it? So in order to do this, I'm using the Health and Retirement Study. Probably everyone in this room has either heard of it or used it themselves. It's a biannual survey of people aged 50 and over in the United States. We're using up until 2012, not 2014, 2012, because that's where the Medicare claims data end. We are using it matched to the fee-for-service Medicare claims data. It's about an 80%, little over 80% match. So people both had to answer yes when they're asked, is it okay to match your survey data with your medical claims data? And they had to have fee-for-service coverage. And so more people said yes, but then they had Medicare Advantage. Medicare Advantage doesn't report their claims in the same way, so are fairly unreliable. And so it's still 80% of the HRS. Previous work has demonstrated that there's no discernible problems or selection in terms of who actually says yes to linking their data. And one benefit, which I'll get into at the end of the presentation, is that we have both the claims-based diagnosis in terms of the ICD-9, ICD-10 codes, but we also have survey measures of dementia. And that becomes really important, again, in trying to tease out why some people got $2,000 and why some people got $130,000 for the cost of dementia. So I'm using a prospective cohort sample, and so how you identify controls is always fun and interesting, and something that, again, becomes really important. So some people said, the people who got $130,000, right, they basically aren't really looking at a matched control, and so they're saying people with dementia cost $130,000 more. Well, that's not surprising because people with dementia are also old and also have a whole bunch of other comorbid conditions. And that's not sort of the incremental cost of dementia. And so first we want to identify a dementia cohort, so people who have an ICD-9 code for dementia. It can happen in anywhere in the medical system, so inpatient, outpatient, home health care, in a skilled nursing facility. Right, 40% of ours are actually coming from an inpatient stay. So someone's going in the hospital and that's the first time that you see a dementia diagnosis. They have to be enrolled in Part A and Part B. We want to, in order to control for sort of pre-existing trends, we want to have them enrolled in Part A and Part B 12 months prior to diagnosis, so we're only going to look at age 66 and above, and at least 1 month after, so that they don't disenroll on the exact month that they get diagnosed. We do allow them to disenroll at any point, at any other point, and we actually do have quite a considerable amount of censoring. 17% is due to people actually leaving the fee-for-service and going to a Medicare Advantage plan. Another 15% is due to people they're still alive, the audacity to be still alive when our data stop. So we don't actually limit, we don't make people die before to be included in the sample. And then we want to look at some matched controls, and we want to try to get it as close as possible to the people with dementia without having dementia themselves. And so we match on their sex, their birth year, and their entry year into the HRS. For some weird sampling purposes within the HRS, you can get in at various years, even if we're the same age. We want you enrolled in Medicare Part A and Part B, again, so that we can see your claims data, and we have the same 12-month prior and 1 month after. And then the additional qualifying criteria is that you have to have no dementia diagnosis for themselves or a spouse for 72 months after the match. And that's mainly just to try to get it as clean as possible of a sample, so that way they're not sort of having dementia themselves 6 months later after we say that they don't have dementia. And we were concerned about the spousal caregiving part. And so having a spouse with dementia can lead to your own healthcare utilization and health changes themselves. And so we limit people who have either themselves or a spouse have a dementia diagnosis. But we do allow up to 5 matched controls per case. So the methods we use are developed by Basu and Manning in 2010, specifically for estimating costs under censoring. And again, like I said, this is really important in this case because we have a lot of censoring. About a third of our sample is censored, and it's not because they're dying, they're censored. So like I said, 17% is due to enrolling in Medicare Advantage, and another 15% it's just 2012, the end of our Medicare data period, and they're still alive, so we don't know what's happening next. The benefit of this method is that it addressed power link of 0.95, and then we use recycled predictions, which every field has a concept like this but uses a different term. So if it's not what you're used to, sorry about that, but it's so you set the dementia indicator into 1, do all the predictions, set the dementia indicator to 0, do all the predictions, and then you can compare. So that way you're allowing for all of the individual characteristics to stay the same, and it's not that you're predicting just for like the non-demented cohort and comparing that to the demented cohort when there's other characteristics that are varying. So it's a way to control for the fact that there might be slightly differences in comorbid conditions, say. Is that what do you guys use recycled predictions? What's the... No, you don't use recycled predictions, I can tell based on the look, but but anyway, so that's the idea behind it. So essentially you're trying to predict for everyone in the sample and control for all of the baseline characteristics. And then we do another generalized linear model for estimating the cost in the month of death. The concern being that the month you die, a lot of people have actually higher than average expenditures, and so we allow that to be different within the sample. And then we estimate their survival function. So we do an accelerated failure time model allowing for differences in survival due to the disease. I'm going to end in 2 minutes if you guys don't ask any questions, so please feel free.
Okay, so I'm just trying to get the concept down, and so I apologize. I never really thought very hard about this ever. So one thing that would, after you said that the costs were low, I thought, why would that be? And then I got to thinking of a conversation I had with Jeffrey Silber not that long ago, who was talking about how, one of the 3 biggest predictors of inpatient mortality, in hospital mortality, was, whether you were demented or not. And it made me realize that being demented may spare/use/the insurance system a whole bunch of other procedures, whether they're hip replacements and things like that. And I can't quite figure out in the kind of causal model where that fits in. I'm sorry.
No. You're right. So there's 2 different things. It could happen, right? It could be that you know that you have Alzheimer's. There's pretty much only one trajectory. It's down, right? So I'm not going to worry about when my knee gives out because I'm more worried about when my brain gives out. So it could actually be saving money.
Or
right.
Or the clinicians. I mean, the people
right.
who are doing the things because they're aware of.
Right. We actually don't see that. We actually see that it is higher, and I'll get into the reasons why. But it could be that it could be cost savings, right? Sort of the whole idea, that smokers used to save Social Security money because they had the audacity to die sooner, so they didn't collect way in the advance. So it also, and we do find that actually effect. We do find a survival effect.
Maybe I missed this, but do you interact the comorbidities with the dementia diagnosis?
We are not currently interacting.
I'm just thinking because I've seen in the medical literature that people are really concerned about non-adherence to medication at one time, and also that it's really hard to get people with cognitive impairments to adhere to medication for obvious reasons. And so that might be one channel through which having comorbidities isn't just expensive additively, but also interacts with your dementia.
Yeah, we could try that. My guess is it won't change that much, especially if it's about prescription drugs that you're worried about, because our prescription drugs, the differential effect of prescription drugs is actually relatively low. And mainly because there's not much you can do about dementia, right? So essentially people are getting on antidepressants or anti-anxiety meds to help deal with the symptoms of dementia, and that's about it, right? And so they're costing about $300.
I was thinking more about you would have dementia, you also have blood pressure.
Right.
So you forget to take your blood pressure medication.
Right, yeah, so that would be picked up in the $300 additional, so it would be a net effect that I'm picking up. But we could certainly try it. Yeah, so we have 4,000 people with dementia during this time period that have a clinical diagnosis of dementia appearing in their claims records. So this is if you guys all have at least looked at old people at some point in your careers, this is not sort of surprising given the age. So, on average, they're over 80 years old. Not very many men are left in the sample at that time, and so it's 37% male. Marital status, again, by the time you're 80 and there's no men left, not surprisingly, there's a lot of people who are widowed. And a very low educational attainment. Less than high school is 40%, high school graduates 30%. Part of this is just the cohort in and of itself, 20% veteran. And this gets at the comorbid conditions. These are just percent that have each one. These are not These are not mutually exclusive, so 30% have diabetes. Right? This is a sick cohort, right? So 40% have anemia. They have arthritis. Right? They have diabetes. 70% have some sort of hypertension already diagnosed. Right? These are not. This is not the healthiest cohort to begin with. Again, mainly due to age. Right, the total expenditures, the average is $16,000, but with a huge standard deviation. Okay, so these are individuals that are costing a fair amount, and these are just Medicare expenditures, just to be clear.
Those are annual expenditures?
Annual expenditures, yeah. So the first results is by, so the survival results, I want to talk about that a little bit.
Can I ask one question?
Yeah.
How do those characteristics compare with those who are in your control group? For this definition, the people with dementia are a little bit sicker than the people in the control group, but otherwise they match up pretty well. So the first results is simply that if you have dementia, and you're female, it doesn't change your survival probabilities. If you have dementia and you're male, you do actually have a lower survival rate. Yeah, isn't that surprising?
And so I'll get to that in a second. So also for college, for education, right? If you don't have much education, it doesn't change your survival all that much. But if you have college level education or above, right, it actually is change your survival, and you're more likely to die or die faster. Everyone's likely to die. You're more likely to die faster after a dementia diagnosis. So this is consistent with the cognitive reserve hypothesis. So that people with college education have sort of more healthier brain and have a more reserve, and then it staves off the dementia itself, or perhaps the dementia diagnosis, because you're able to hide it. But then once you're diagnosed, you actually have a much faster decline. Like sort of the reserve has been depleted by the time you get a diagnosis, and you have a much faster decline. So this has been documented a few times. The gender one, we kind of puzzled about it, as you guys suggested. Because so many people are female who get it, they're more likely to be living alone, less likely to have caregivers. We kind of first thought that females would have a bigger survival impact, but it's basically related to competing mortality risks. So men are getting it younger than women on average, and it's associated with if you're married and young, and eventually we think it's a competing mortality risk. So women, by the time they get it, they're going to die of something sooner or later. Right? Men who get dementia are getting it slightly younger than the women are. They're more likely, so it's less likely that they will have died, will have something else that would kill them in a complete, in the near term.
Do you imply that your survival curves don't control for age? At this point, it's just
it is controlling for age, yeah, but we think it's more about an age of onset story, right? So that you're getting it younger. The one thing that we did find surprising is that we aren't finding any association with race once you control for education. We're not finding an additional factor with race, despite the fact that the medical literature is filled with stories about how if you're a minority, you get diagnosed much later in the disease, and so, but we're just not finding anything statistically on race.
Isn't that consistent with your story? If you get diagnosed really late, then there won't be differential effects.
Well, then you should see me dying very fast by the time I get diagnosed, right? If I got diagnosed really early, then perhaps you don't see any difference. But if I get diagnosed really late, I get diagnosed the day before I pass away, then you should see a big difference.
So there should be, if the popular story is true, there would be big difference.
So if what story was true?
The story that you hear that you're not confirming. The standard view of race is that African Americans are treated worse.
Right.
And are not diagnosed as quickly.
Right.
And therefore, you'd find a bigger effect.
Right.
You expect to find a bigger effect.
So I expected to find a differential effect by race. But once you control for age of onset, we're not finding any differences. So this is the average total cost, the average total cost by the claim-based diagnosis, which we've been talking about. This is how sort of the Part A and Part B, which is inpatient and outpatient costs, how they evolve over time. And so this is 0 is the date of diagnosis for the demented cohort, and the pseudo date of diagnosis for the non-demented cohort. Right, and this is essentially what we see. Huge spike right at the time of diagnosis and leveling out, but still a slightly higher effect overall than it was prior, and it sort of continued on over time.
Do you think that's because they were in the hospital?
This is exactly because they were in the hospital, right? So 40% got diagnosed in the hospital. So that first hospitalization is showing up right there. And it doesn't. We don't know why they're in the hospital. We just know that that's the first time that it showed up. And so they could be in the hospital because they broke their hip, because they fell, which could be because of dementia, or it could be due to other reasons.
Can you check in the claims data? What are the other, you say dementia diagnosis, but are there other diagnoses that happen?
Oh yeah, there's lots of diagnoses that happen. Pretty much every time you go into the hospital, everyone gets a whole bunch of new diagnoses. And when we've been talking to the geriatricians, they say they don't know if it's a function of, they hypothesize it's a function of basically how good hospitals are at coding, because anything gets them money, versus an outpatient visit, that it may be that they're showing up anyway. Their primary care doctor knew something was going on but didn't bother to bill it because it didn't make a big difference, but the hospital is going to do that. So we can see what's going on in the hospital, but again, every hospitalization leads to a lot of different new diagnoses. Yeah.
Can you help me with the intuition on the control group?
Yeah.
Why over time is there no association between costs and tolerance? I mean, people are getting older, right?
People are getting older. Yeah, so this is controlling for sort of age.
Oh, it's
right. Yeah.
It's time.
Yeah. Yeah. So if you break it down by time period, right, for the first year, second year, third year, fourth year, and fifth year after diagnosis, right, huge impacts. Again, the first 2 years, a lot of it is being driven by hospital costs because you're getting diagnosed in the hospital. But still, even if you got diagnosed in the first year, you're not being diagnosed the second year. You're still having a lot more costs in the second year. And then after 5 years, we're really seeing a dwindling of the costs. So, it's about $15,000 over the course of 5 years per person. So like I said, we were on the lower end of the estimates. And a very, very striking time pattern.
But this won't have the cost of nursing homes.
No.
This won't have nursing homes, no.
And isn't that the big cost?
So it does have some nursing home in it. So it does have post-acute care that Medicare covers. And so if you're in a hospital and get diagnosed or get sent to a nursing home for something that you're recoverable from, Medicare will pay up to the first 100 days. And so that is actually one of the big drivers in here, is that you're going to a nursing home after a hospitalization. We're in the process of adding the Medicaid data. Next month we'll have the Medicaid data, and as well as the out-of-pocket costs. And so we'll be able to add that part on. But that's kind of what I think is sort of surprising, that you could look at the acute care costs and see such a big difference. Like I said, the estimates were $130,000 on some cases, right? Because there isn't anything you can do about it. You think about it, at least I have always thought about it in terms of the long-term care costs and the nursing home costs that Medicare isn't covering. But still, if you add $15,000 over 5 years times 16 million people, right, it is going to be considerable costs to the Medicare program.
So do you think those costs were per person that you showed earlier? Those were all Medicare costs?
These are all Medicare costs, yep.
Even the earlier estimates?
Yep.
And they were per person?
They're supposed to be, yep. Yeah, so some of them measured like, this year versus over 5 years or over lifetime, so there's differences in that as well. Most of the major differences were being driven by whether or not you're controlling for other diseases, the comorbidities. And then I'll talk about the last one is sort of the disease onset actually changes a lot, the definition of the disease. So here we can break it down into survival effects and utilization effects, right? And so this says essentially that if we had no difference in survival, it would actually cost $17,000. By the fact that dementia kills people, it leads to lower survival. We're actually saving a little bit of money. And this is the Part D costs, and this, so very, very small effects if you take into the prescription drug costs, $300, $400 a year. We do actually find, this is one good thing, we do actually find that individuals with dementia are actually costing less in the last month of life. And so, the role of advanced directives or things like that, people aren't, there is a lot of concern about people in nursing homes are getting shuttled back to the hospital all the time. Joan Tino has a bunch of work showing that people with advanced directives in nursing homes have increased utilization in the last 6 months of life by 700% over the last 15 years. We actually find that compared to those without dementia, they're actually using less utilization and costing us less in the last year of life. And then here's the differences between men and women, the incremental costs. And again, because men do have a survival effect, that's where the savings is coming from. So women are costing $17,000. Men are only costing about $10,000. So it's a pretty substantial difference in the costs. We tried to look at what is causing these differences, again, because there's no cure. So what is driving these costs? Why are people being treated differently, essentially? And it is hospitalizations. So part of it, at diagnosis, you're more likely to be in a hospital, but also over time, there's increased hospitalization for this population. Once you're in the hospital, you're more likely to be charged to a skilled nursing facility, and the first 100 days are covered. And then the mortality differences for men is driving the results. So what can we do about it? This really argues that delaying onset isn't really going to help, because most of the spending is in the first year, maybe 2 years of the disease. And so there's not really much sort of delaying onset, just sort of changes your discount rate by another year. It doesn't actually save us a ton of money. And what we should be focusing on is early detection and really thinking about these preventable hospitalizations. And the number one thing is falls, because Alzheimer's both increases falls because it can change your gait, and it also may put you in situations where you're not making the best decisions. And so falls go up dramatically among this population. And so this argues that instead of focusing a lot of time and money on delaying drugs that may delay the onset, we really should be focusing on early detection and screening.
So do you think the hospital costs are the same regardless of the age at which they get diagnosed?
Trying to think if we've done that. I don't remember if we looked at that, whether or not the hospitalization is different by age.
Yeah, I don't know.
I don't remember if we've done that. I know the survival is a big difference, but I don't remember if hospitalization. And then the question that sort of is now percolating in our minds is, or does it? Because one of the reasons why the literature varies so much is because they're using different definitions of diagnosed dementia. And so if you use claims data, this is what we find. But some people have different data sets, and they can use survey measures, or they have doctor's visits or EMRs. And so you can look and really do a intensive cognitive battery, which may be very different, right? And this gets into Irma's earlier question, sort of people are in the hospital and get diagnosed there. Is that because no one knew about it, or is that really because hospitals are just really good at billing? And so we looked in the claims-based diagnosis, and we looked in the survey of the health and retirement study. So there's various measures you can use in the health and retirement study. This is the one that Ken Langa and his colleagues use a lot. Looking at the TIC score and serial 7s and your memory scores. So can you name the president? Can you subtract 10 minus 7 minus 7 minus 7, or 100 minus 7 minus 7 minus 7, and how well do you do on those tests? And you get a fundamental sort of difference in cost, and mainly, again, because this is sort of masking this, right? Because if 40% of the population is getting diagnosed in the hospital, that hospital stay is being attributed to dementia. Here, on average, people are being diagnosed in the survey for the overlap group 12 months prior to it showing up in the claims. And so here, this is where the hospitalization is occurring, and it's sort of being averaged over a much longer period. It's not sort of this spike. And so you get a very different story about what is the cost of dementia depending on when you sort of say this is the day you have dementia. And so we do the same thing for the survey-based diagnosis. We have to go back and rematch the cohort and reanalyze the data. And we wind up with a very different pattern of spending. So this is the numbers you've seen so far. You know, the totals aren't dramatically different, 11 versus 15,000. But the pattern of spending is very different. And so, you know, this is actually increasing over time slightly, statistically. And it's very, very sort of a smooth pattern and sort of not this big spike.
Do you know the time of diagnosis very precisely from survey data?
So we don't. So we have 2 surveys. We know when they passed the test and we know when they failed the test.
2 years apart.
It's 2 years apart.
So months 1 to 12.
Right. Right. So it could really be between this month, these months, or actually in the pre-period, right, in the negative 12 to 0 months, because we don't actually know. We assign it the midpoint the first time between the 2 surveys in which you failed. Yeah.
About the measurements in the survey.
Yeah.
Because what you mentioned is the test that they administer is basically this is a standard test that you administer just to capture age-related normal cognitive decline.
Yep.
And I'm not aware of how, you know, age-related normal cognitive decline is different than having been diagnosed with dementia. So is the survey really diagnosing dementia, or are you measuring something?
So I defer to all of the cognition, the medical doctors and neurologists on this one, and punt to Ken Langa's work. And so what Ken has spent a fair amount of time doing is trying to match the best you can do in survey data based on neurological evidence. And so they have an ADAM study, which is a particular memory study that's done to, I think it's about 1/3 of the population during the summer. And then they try to match the people who get diagnosed from that to the full sample, and they come up with predictions, sort of cognitively normal, potentially impaired, and then impaired. And so we're sort of piggybacking on his definitions. Yeah.
How do those 2 groups align? Like, what's the share of people that have been diagnosed on the survey that are actually diagnosed?
It's frightening. So there's a couple of different survey-based diagnoses. Again, this is the one that I said that Ken Langa's been using. There is also just the question of, have you ever been diagnosed with a memory-related disease, or have you ever been diagnosed with dementia, depending on which wave. The overlap between that and the claims-based diagnosis is shockingly bad. So if you say that you've been diagnosed and that the claims say you've been diagnosed is a very interesting Venn diagram. This one is a little bit better by using the actual sort of memory tests. The overlap is much better. It's about, I think it's about 2/3 of the people who of either sample are in both samples. So there's 1/3 of people who are measured on the survey-based diagnosis that aren't diagnosed in claims, and similar, the people who are diagnosed in claims and aren't showing up as memory impaired during the survey. And so this is the when I'm talking about we are talking about the overlap group. So when I compare between the 2, I'm talking about the overlap group. But there are a lot of different groups based on how you try to measure cognitive impairment. That's one thing. We just want to write a paper with just Venn diagrams, because it's so amazing how little correlation there is. I kind of thought there would be a lot more overlap. Was there another?
Yeah. In the claims data, do you also have the physician data?
Mm-hmm.
And you have very few diagnoses from the physician claims? It's mostly in the hospital?
So 40% in the hospital, so it depends on your definition of very few. 60% are elsewhere, but it could also be in a SNF. So I don't know off the top of my head how many are from your primary care doctor. But 40% was the large one, sort of in hospital, since it's driving all the costs. So more to come. I told you I was going to end really early without any questions. So we're going to be looking more at cost drivers pre and post diagnosis. Again, what you were saying, studying more what's happening in those 2 years between the survey. We know you're fine versus we know you're not fine. What's happening in terms of your medical utilization. We're adding Medicaid, hopefully within the next month, and out-of-pocket costs, because I think the Medicaid is the bigger story, although, or actually out-of-pocket costs I think is the biggest story, and then Medicaid, because you have to basically get rid of all of your wealth in order, before you're eligible for Medicaid. So I think a lot of it is going to show up in the out-of-pocket costs. We do have access to the ACT study, which is an ongoing cohort study, incident cohort study of people in Seattle area, done through Group Health, now Kaiser. And so they're matched to the EMR records. It's been going on since 1992. It's very convenient that they decided to start these things at the same year. Must have been a boon in NIH funding or something. And so we have that matched to the Medicare claims data, Medicare Advantage claims data, because it's within Group Health / Kaiser. Right now we're finding that not surprisingly, there's a lot more costs being driven by SNF care costs in the Medicare Advantage, but that's because of the difference in insurance. So Group Health did actually cover nursing homes, not just for the first 100 days, so we're teasing that part out now. Like I mentioned, we're doing the welfare cost to informal care providers. We just submitted that paper, and so we're finding that the welfare costs vary tremendously based on the disease of the parent. So if the parent just has an ADL or a physical limitation, the welfare costs are in the $140,000 range for every 2 years. When it gets to the point where they have both physical limitations and memory limitations and they can't be left alone for more than an hour, the welfare costs are over $200,000 over 2 years. And so the informal care is really where the money is, and we do very little right now to compensate the family members to do that. And then finally building the forecasting model so we can actually figure out whether this is going to cost both the system as well as individuals who have dementia. So I ended fast. Questions? Yeah.
So I can think of two different ways of doing the total cost estimate. One, based on the incidence of Alzheimer's times the amount that each incident will cost over their lifetime. You're sort of, it seems like, heading in that kind of direction, but you need good incidence data to do that. And you need good mortality data. I mean, it's not reasonable to assume they're going to survive for 5 years and some will survive for 15 years, which is obviously going to add to the cost. Or you can do cost per diagnosed person and apply it to the prevalence of Alzheimer's at a moment in time. You didn't do either in the paper, but maybe you have done so, and if so, which one are you getting?
So we're leading towards the first one. So other people have done sort of what is Alzheimer's costing us today, right? And so, which is a function of how many people are diagnosed, what stays they're diagnosed, right? It tells us what. To me, I think the major limitation of that, it does tell us what we're paying for the disease, but it doesn't tell us if we change the onset or if we change the trajectory. It doesn't tell us what happens to cost, because it's sort of a function of how sick people are today, and you kind of can just sort of multiply that by the number of people who are still going to be alive tomorrow, and it kind of assumes the disease trajectory is going to be the same, and the number of people sort of early onset, late onset, or where they are in the disease is going to be the same.
But that, of course, depends on the age distribution of the population and changes therein, and if there are going to be big changes, so you obviously have to factor that in.
Yeah. So we're worried about not only just the aging of the population, because that's a big thing that changes the prevalence. We're worried about the incidence rate, which is going down. We're worried about the marriage rates and the number of children people have, because that impacts the cost, at least in terms of, we know it impacts the informal care providers and whether or not you have any. And our next step is to see how much Medicare costs vary whether or not you have a spouse or not, and and how much it costs your spouse. Right, because caring for someone who has a mental illness is not an easy thing, and we know it increases antidepressant use among the caregivers as well. So we're going to try to build, lofty goals. We're going to try to build it all in. Yeah.
Regarding your conclusion that age at onset doesn't matter for cost because the first year is so important, I'm wondering whether you've explored some age at onset stratification or interactions, because from your graph, I mean, yes, we see that big spike that first year, but we can't really tell whether the difference or the size of the spike varies depending on age at onset. And if it does, then you might have a different conclusion.
Yeah, okay. So like I was saying, we did a lot with the survival with age at onset. And again, we find that it's mainly men who are getting diagnosed early have the biggest survival effect. And so that's being accounted for in the sense that people are the survival impact is being accounted for. But we haven't looked specifically at sort of whether or not age at onset outside of the survival changes a lot. Yeah.
I'm having a little bit of, maybe it's just my confusion, maybe you can help me understand how your model works better. I guess the question has to do with the extent to which Alzheimer's and related forms of dementia contribute to the incidence of other kinds of disease situations. Okay, so let's say you lose awareness of where you are and you fall more often.
Mm-hmm.
Okay? So you're controlling for the costs of falls, and I guess what I was my understanding was you're trying to estimate the net effect of Alzheimer's, net of all the other conditions. And the extent to which Alzheimer's contributes to some of those conditions seems to me to be kind of part of the story. I guess the question I have is where does that show up in your
So that is really important. So what we're trying to do is we are trying to do control for the sort of the incremental cost of dementia, but only control for things that existed prior, right? Because anything that happens after the onset could be attributable to dementia. And so that's why when we see these big spike, right? We don't want to say this hospitalization could be because of dementia. It could be because of any other reason. We can't tell exactly why you fell, right? Say, and so we're going to attribute that to dementia because it could be, right? So it's essentially if there's anything differential that's happening among this cohort. So they have this wouldn't happen, but they have a spike in diabetes, and all the diabetes care would all be attributable to dementia. Right, because that's happening after the diagnosis. So we've been working with doctors to try to make sure that we don't over-control, because if you control for too many diseases, then you're missing the effect that dementia is correlated with a lot of other things that happen in comorbidities. So we want to only control for things that are happening prior.
But the flatness of those two lines suggests that the dementia is not contributing to other. It's not kind of cumulatively. Results in
right. It's not. It's initially, but not in the end. Right. That the things that it's contributing to are not differentially more expensive 5 years later. So it may be the case that so I have dementia, so I fall. It's causing me to have a hospital stay soon after because I don't have it under control and people aren't aware that this is a problem. Right. And then eventually everyone's falling, and so the differential effect becomes nothing.
But isn't that compatible with what I'd asked you originally? I mean, the idea that because people have dementia, when other things occur, there may be among, whether it's family or clinicians, a compensating propensity not to treat as much?
Right, it's the same thing, right? So it could be that, it could be lower because I'm not getting my hip replaced. It could be higher because I'm falling more, right? It could go either way. Yep, we haven't looked too much into sort of what's happening here. It sounds like that would be of interest in sort of what we know. It's hospitalizations and being dismissed to a SNF, and being dismissed to a SNF to a skilled nursing facility. We actually thought that was probably good care, right? People who with dementia have a hard time recovering to begin with. It's harder on the caregiver to recover because you not only have a broken hip, but also dementia, and so it may just be better care that they're being able to have the SNF stay. And so we didn't really worry too much about that. We are in the process of looking through and seeing what the hospitalization is. Are these things that the Medicare has deemed as potentially preventable hospitalizations?
I also think that could be because once the SNF care or the skilled nursing home care you can't have it anymore, then you switch to Medicaid, and you could see a huge spike. My guess is that if you put overall costs together,
Yep.
then there would be an increase in costs over time, because once they get moved from
Yep.
the skilled nursing home facility to nursing home care, and that's going to be paid either by out-of-pocket or by Medicaid,
Yep.
then you wouldn't expect Medicare costs to keep going up because it's being picked up by something else.
Right. So my guess is that we're going to have like a 5-year thing here for Medicare. We're going to have increasing out-of-pocket costs sort of starting in year 2, and then increasing Medicaid costs probably a little bit later. My guess is 4 or 5. We'll see how good I am at predicting that. But that's my guess, that essentially different people are essentially picking up the bill.
So the family may take it for a while, and then, but then the
Or you're in a nursing home and you're paying out of pocket because you're not poor enough to cover for Medicaid.
so it also then is likely that the welfare costs to the family are going to change over time too, right?
Yep.
So do you think, and that's partly because Medicaid will pick up the nursing home.
Right. Right. So the welfare cost estimate that we have is for people who are living at home and being cared for by their family, and so that would, for the most part, go away when you're in a nursing home. Although some people argue that the informal care costs actually go up right upon institutionalization because people expect sort of a relief, and then it's not. They're still very, very active in the daily life of someone in a nursing home, and so it may actually be that institutionalization is worse, at least in the beginning.
So this is fascinating. So
It's fascinating or confusing. Either one. You take your pick.
So if I'm pulling the right thing out of this, I realize you're a long way from done, but I mean, based on what you found so far, you're saying, okay, this is a disease or a condition where the counterfactual Medicare costs are actually, not so bad and so on, but the welfare costs are high. And so if you take the ratio, and I realize there's a lot of stuff that still needs to be done with Medicaid.
Yeah.
And
Yeah.
people using their own assets and all that kind of stuff.
Yeah.
But the ratio is pretty high. So I guess I'm curious, do we know, I should look at some of our aging experts, I mean, do we know across classes of diseases what the sort of ratio of welfare costs to
acute care costs
are? I mean, are there different disease typologies at this point?
I don't know of any. Does anyone else?
This has to be about the highest.
Yeah.
But I mean, right, and it's okay. It's fascinating. It's so fascinating. Now I'm going to apologize that I have to run out here to go teach.
Yeah, no.
So let me just say one other thing. Is
Yeah.
that one comment you made was that you guys wanted to do a Venn diagram.
Yeah.
Again, since I don't know the literature, maybe there's a lot more stuff on this, but I think that would just be fascinating because, as a non-medical person, as a non-biological scientist and so on, but just a kind of observer of people, I know how, Michelle will know this technical term, people get a frisson. People love anything that sounds science. And so when they can start coming in and talking about autopsies and plaque in your head and things like that, people get really excited because it's not like social science, it's not mushy. It's exciting. You can actually pull out some ganglia and stuff like that. But what you're pointing out is that given the way this interacts with the insurance system and so on, there's a heck of a lot of unknown, even for something that once you're dead, once you get your skull lopped off and they get to start touching the stuff that makes everybody happy, that they can actually diagnose who had it and who didn't. But
Right.
in the interim, the whole thing's really messy.
Yeah. And one of the doctors we're working with is actually sliced heads open and diagnosed 4 different types of Alzheimer's disease. And so we're going to then match that to the claims data and see if the different types, but he can categorize them as different trajectories, and that's why he cares about the 4 different types of Alzheimer's disease. And we're going to see how much it aligns with the cost effects.
Question,
Yeah.
the stuff that excites us because we get to pretend like we're real scientists and the doctors our parents wanted us to be, actually maps into anything.
Right.
People are actually paying.
Yeah.
Interesting.
I have a clarification question.
Yeah.
Why do we call the informal care workers welfare costs? Aren't they paid through Medicaid as well? So are we talking about if I'm poor and I have disability and I have a right to have a home care worker, right?
So that would show up in the Medicare or the Medicaid costs. So any home health care worker is going to show up as someone who's paid in either the Medicaid or the Medicare claims data. Informal care are the unpaid family and friends. So this is your daughter not being able to work because she's taking care of you.
How are you calculating that? How are you calculating the cost of that?
So we build a dynamic discrete choice model. So we try to actually come up with a welfare function. We look at what people actually do in terms of their labor market and in terms of caregiving.
Opportunity cost kind of idea, or like what they would be gaining if they had been working as opposed to caring for a family member?
Times about 5, right? So the welfare, the opportunity cost, basically, we also try to take into account the value of your leisure. We take into account the fact that you've changed your work behavior. So how much does it change your ability to get a job if you decide to go back? How much does it change your skill set so that what your earnings could be when you go back? And so this is the big money part.
But if the home care workers are already in the data that you have, it's kind of surprising that they aren't increasing at some point. Are people losing breaks to actually unit
So
those things?
that is mainly because it's Medicare. And so Medicare just doesn't cover a lot of home health care.
Okay, so when you add Medicaid, then you would see those in there.
Then you're going to see more in that, yep.
Okay.
Yeah, because the Medicare covers essentially home health care for rehab, so it has to be something that you can recover from. So we don't have any propensity to recover from dementia as far as we're aware, and so just having a dementia diagnosis wouldn't get you a Medicare benefit. There are people with home health care, if you have a stroke and dementia, right, then it's still fine. You can get help with walking or occupational therapy to help you recover from a stroke, and so that's in there. But it's very short, under 100 days, and it has, again, it's not going to be specifically for dementia. It's going to be for something else that's happening to you.
So, Liana, did you have a question?
Yeah.
Just clarification. So, if I understood correctly, you basically group everything. Alzheimer's plus different type of dementias, this is one category.
Yep.
But you pointed out before that even if you look at specifically at Alzheimer's, there are, like you said, 4 different Alzheimer's trajectories that are different in terms of progression, severity, and so forth. And then we have, on one side, we have the Alzheimer, and then we have all the different type of dementias, such as, cerebrovascular related dementia and so forth. There are different rates of progressions, different severity, and etc. So wouldn't it make sense in your analysis to split both and look at specifically at Alzheimer versus other types of dementia?
So if I believed the ICD-9 codes were 100% accurate, I would totally do that. But most of the time, it's generic dementia is coded, and you don't know until after people die and they slice your brain apart exactly what type of dementia you have. So Lewy bodies is one that you actually can tell ahead of time. There's tests you can test if you have Lewy body dementia, but that's 4% of the dementias. So it's sort of not a big enough sample size that I feel like we could actually estimate this reliably. And that's why we're going to the other data set that does have brain scans. And so we can, after people die, we can go back and say, this is the type you had. And we can then look and see if there's differences in cost. But I agree, it would be lovely if the codes were good enough that we felt like you could diagnose it, but it's really hard to diagnose in general, and then the codes are, they flip-flop between 3 to 4 different types of dementia based on where it is or who's coding it. I just don't feel like it's reliable enough to say we can do that. Yeah.
So, great talk. I wondered if you could talk a little bit about the justification for using just 12 months before, given that we know that cognitive decline and dementia progression is sort of this continuous process, that the diagnosis just sort of splices this continuous process at a somewhat arbitrary point. Just the 12 months, and given especially when you put the 2 graphs up about the survey methods for sort of understanding cognitive decline and the diagnosis data, it seems that there was sort of an observed baseline difference between, even at prior to 12 months to diagnosis, there was this sort of baseline difference between those with dementia and those without. And so I wondered the extent to which folks with dementia are potentially accumulating dementia-related costs, cognitive decline costs, even 2 or 3 years out.
Yeah, no, that's a great question. The answer is not as good as the question. The answer is simply because we didn't want to eliminate essentially people who are age 66, 67, 68 getting diagnosed by having this huge run-up of saying you had to be in Medicare fee-for-service for 3 years beforehand so that we can look for the pre-period. And again, we're using this also with the Medicare Advantage, so we wanted to make it as parallel as possible. But I think that your point is well taken, that especially when we're looking at the fact that the survey reported is earlier, we really need to be thinking about what is the right time frame that we need to be thinking about for matching.
Any other questions? I have one.
Okay.
For the projection model,
Yeah.
or forecasting model, I don't know whether you thought about it yet, but you're going to have sort of 2 mortality projections, right? What is going to happen to those with Alzheimer's or dementia and those without, right?
Mm-hmm.
And I guess that's going to be a bit of a challenge to have you thought at all about how you might, I mean, mortality is either, old age mortality has been declining, right? We might think that someday we're going to have some kind of...
Eventually everyone's going to die.
Eventually everybody's going to die, but maybe if we push up the onset as well, that's going to change potentially the path. And also medicines could change the path for mortality for those with Alzheimer's. So that's a huge challenge.
Yeah, so right now we have a list of all the things like that we have to deal with. And that's as far as we've gotten, is the list of things that we have to deal with. We're working on it. And we're going to have to make assumptions that somebody's not going to be happy with to at least get something started. I feel like at least if we make this step, it'll be better than just saying it cost us $10 billion this year, and then then when we triple the rate, it's going to cost us triple the cost, which I think it's not probably true. So I want to try to at least account for at least some of it. It won't be perfect the first time around. Maybe then they'll fund more work on it. And you can tell me how to do it right.
Any other questions?
One last question about the sex-specific results, which are very interesting and somewhat surprising. It's so surprising that I was wondering whether it's corroborated somewhere else in the literature or that's something new. But then your interpretation that this might be due to competing risks.
Mm-hmm.
I think you could actually test that with your data. That's another case where stratifying by age at onset might help, because then you can compare men that have a 70-year-old age at onset versus female that have a 70-year-old age at onset, and see whether the trajectories are the same or not, or the differentials are the same.
Right.
Controlling for that in a way.
Yeah. So it is both. It is both corroborated and not corroborated in the existing literature, because they've found it both ways for men and women. So we contribute to one side of it, but there are papers that disagree. So I'm not sure if it's surprising. There's differentials that people have known. It's unclear which way it goes. The education one is definitely not surprising, but the gender one was mixed in the literature beforehand. So we're just kind of one more point. I don't know what to think about that. We're one more point.
Okay, thank you very much.
All right, thanks so much for your attention.